Hello, and welcome to the Florida Combined Otolaryngology meeting. I'm Dr. Natalie Phillips. This is Dr. Danny Mystery, and we are excited to present our topic to you. So we are going to just dive right in and start our topic. All right.
Good morning, everybody, or good afternoon, wherever you're in the world. It's an honor to be here to present to you. And our topic for today is the concussed year, contemporary pearls for integrative care. And working with Natalie has taught me a lot about the inner ear as it relates to concussion. So our goal is to provide you with a synopsis of what we do and where we are moving for the future and how we can be better each day. So, traumatic brain injuries, as we know, we use the term interchangeably with concussion being a mild TBI, mild traumatic brain injury. There's nothing mild about it, but it's classified as a mild TBI based on the GCS scale. But basically, they deliver complex physical, emotional, and cognitive symptoms, and patients sometimes suffer for very long. And our goal is to get to the nitty gritty details of why they're feeling that way. And more specifically, we know from experience that there's the disruption of sensory input that can affect the integration of input in the brain, leading to disordered motor output and thus involving the ear and balance system, but not just the ear and balance system, but also cognition, as we will talk about a little later. It is absolutely imperative, and we kind of owe it to our patients to provide them with careful, comprehensive um, care and using an integrative approach to create a differential diagnosis and then start the management, which 95% of the time involves evaluating the inner ear first. I can tell you that there are very few patients who I do not send a referral for inner ear evaluation, and those patients have already had some inner ear evaluations. If they haven't had it, even if they're feeling fine, and we are seeing them a year to 2 years after their concussive injury, it is amazing and not surprising anymore as to how many of them have some form of inner ear dysfunction. And Natalie's role is to figure this out for me to make my life easier and to then heal our patients. So this course is going to discuss the roles and value of this collaborative care that we've established in Fort Collins and hope to establish elsewhere for other folks when we focus on understanding those otologic pathologies and how those are important to heal in order for enduring recovery from traumatic brain injury. So at the end of this course, all of you will be able to formulate a differential diagnosis of the pathologies associated with brain injuries and concussion, identify at least 3 specialty professions and their value with an integrated approach to the evaluation care of the inner ear as a cornerstone to enduring recovery from concussion. So simply stated, when we think about the inner ear and that remarkable vestibular organ connecting to the cochlea and then through one nerve to the brain, when we think about that as the nerve center for concussion recovery, people get better. If we don't pay attention to that, as we know, the vestibular ocular reflex is very key for gaze stabilization. And people who have gaze instability because of the inner ear being ticked off after a concussion, then the patient never gets better. So we need to know what's going on, whether the pathology is peripheral or central from a vestibular standpoint, and whether the VOR is disrupted, and how those are working together to help the patient heal. And this is something that we've shown in hundreds of patients. So the simple truth of integrative management of traumatic brain injuries is that we need a comprehensive evaluation. We need meaningful rehab, and that needs to be early. But many times we don't see people early. In fact, I can tell you that most of our patients, we see them many months after. Unlike the athletic arena where we have athletic trainers, and I'm an athletic trainer myself, and having been in that field, I know that we can see athletes on the sideline right away, but that's not real world, especially with people who've injured recreationally or through personal injury, like whiplash injuries and car accidents that cause concussions. But the early intervention can be as early as possible, which makes a difference. It's also important to develop a network of the team that takes care of the team. So if you look at the second picture below the brain rehabilitation picture, can you go back one slide? We have a team that helps. So we have a audiologist, ENT, optometry, ophthalmology, clinical psychology, school psychology, neuropsychology. Based on what we find, then we direct integrative therapies, and then as needed refer folks to neurologists for headache management, medication management. And then we have an outstanding concussion neurologist at UC Health in Fort Collins, and we also have an outstanding concussion neurologist in Boulder, who we refer to, which makes our patients' lives much better. Um, and the third part of this slide talks about the integration of audiology, ENT, and optometry for almost all our patients. On the next slide, we find, and the print is fine, but if you can look at the importance of the integrated approach is vestibular, ocular, cog rehab, and then also paying attention to how do we return folks safely back to work and how do we return them safely back to sports. The root of all of this is in understanding that concussive symptoms can be in four domains: physical symptoms, meaning ocular, vestibular, cervicogenic; sleep energy; cognitive, which is memory processing, speed, attention, executive functioning; and emotional and mood. And the overlap of these symptoms, like which is kind of depicted by a spirograph, and if you know what the spirograph is, we used to draw those cool shapes, is to think about the fact that we don't separate these symptoms. One system affects the other system, right? We know the brain is this amazing conglomeration of 100 billion nerve cells with 150 trillion circuits. So it would not be medically prudent to separate out, oh, I'm going to just treat your physical symptoms. I'm just going to treat your cognitive symptoms. I'm just going to treat your emotional symptoms. They're all linked. And it begins with the inner ear and ends with the inner ear. Shocking, but true. I touched upon this a little earlier, and we can pass on this slide because we've already talked about the fact that we need meaningful rehab. And the approach we have in our clinic begins with one simple fact, that everybody's involved, not just the healthcare provider. It begins with the individual, the parents, and the family. In the school system, it is very important to get the feedback from the teachers, coaches, and support staff. And then when the healthcare providers understand that it's a team approach, people get better. So we kind of pride ourselves in paying attention to a team approach, right? So the care model, just a little mnemonic, is we've committed ourselves to a simple fact that this is not an easy field, but we have to all as a team commit ourselves to excellence. We got to communicate well with all our providers, and we got to give them a consistency of care. When we do that, there is a tangible difference on the patient feeling that, my providers are talking to each other because I'm not feeling right. This is not who I am before the concussive injury. Within that realm, making access to care as smooth as possible is key, making it affordable. For example, our clinic has the patient population, 60% of our patients have Medicaid, which is fantastic. Medicaid, I can tell you, is actually a fantastic insurance company. They've rarely denied care for our patients. And I recently did a presentation to about 40 caseworkers with Medicaid, and creating a system where you work with the insurance company, work with their providers, making it affordable for them while making them aware through education while they come for their first visit is a powerful tool. We also need to know that the brain is individual, right? No two brains are alike. Therefore, no two concussions are alike. And being resolute about this fact is very, very helpful. Last but not least, the E is evolution. And we got to adapt to change and the principles of medical management over time. Point in case being here that we've learned over time that vestibular ocular evaluation and rehab is the key to success in concussion management. And so what we have done is part of this evolution is we've contracted with the top researcher in Arizona at A.T. Stills University, Tamara McLeod, and she's going to look at the 900 plus concussions that we've taken care of and trying to see what the role of vestibular ocular evaluation rehab has been in the success of discharging almost 900 patients. Educating patients is a process which begins at the first visit and it continues through every visit, and then doing the best to provide expeditious care, because having a patient wait for 2 to 3 months with a concussive injury before you see them and start this integrative care is harmful to their psyche in many, many ways, because it affects every part of their life, physically, psychologically, socially, psychosocial, emotionally, and of course, from all the physical um, objective data that shows that the eyes and ears are not working together. The key point to understand is that brain injury is a complex problem. There's a processing dysfunction, and that processing dysfunction allows us to understand that if we group these symptoms in 4 domains: effective energy, physical, cognitive, and emotional, then we understand, based on that previous slide, that all these domains are connected. So they're separate here, but we need to understand, I put the 4 ovals separately, but they're all linked together within the confines of what we're trying to accomplish with our evaluation and care. Excuse me. The about 5 or 6 years ago in Grand Junction, when I was practicing there, I was working with Dr. Jennifer Beebe, and I let her know that I'm moving to Fort Collins, and she said, you need to contact Dr. Natalie Phillips. Ironically, Dr. Natalie Phillips was in the same medical plaza where I was working for a few months. And so I blind called Natalie and said, hey, I'm a concussion. I've got a strong interest in concussion. Dr. Jennifer Beebe gave you a great recommendation. Can we meet for a little bit? So we met. And at last year's presentation, Dr. Phillips had presented the case study about this remarkable story about a trooper in North Carolina who, because of Dr. Phillips's work, we were able to heal. And we had students who were working with this individual come down to Fort Collins. And we did this all in this same medical plaza, which is an incredibly karmic experience, so to speak, that somehow all these pieces came together, just like the knowledge that if we separate the eye from the ear, people will never get better. So at the first visit with my patient, the first question I asked them is, have you seen an audiologist or an ENT? Have you seen an optometrist or an ophthalmologist? If they haven't, this is the launching pad for good concussion care. So we'll talk a little bit more about that as we move forward. We know from experience that in health, the input from the vestibular system through the VOR to both eyes passing the midbrain is homogeneous, it's even, right? But when we are concussed, we don't know if that evenness is disrupted. And therefore, testing that in a year and getting the optometry testing done to look at the VOR is key for us to understanding the loop of the VOR, because once we work with that, then people get better. The reason I put up those rocks over there is that is schematically the fine input into the brain, right? What I tell my patients is, I'm a chef by hobby. If I gave you bad food by mistake, you would have nausea, vomiting, diarrhea. If you gave your brain bad food from your inner ear and your eye, which is the primary processors for the brain, then the brain's not going to think right. So the cognitive dysfunction is the analogy to a disrupted GI system from food poisoning. So the concussion is the food poisoning, the brain dysfunction is the GI distress. And therefore, showing them this first slide as to explaining why this is important is very key. Also explaining that if they have tinnitus, then we need to understand what's happening with their hearing. And just because my bedside test of either a finger rub or a whisper test, as we know is the gold standard for bedside testing, which I stopped doing during COVID for obvious reasons, is getting that audiogram, because we know hearing loss is associated with a very significant risk for dementia. And so getting them to see Dr. Phillips or any other audiologist or ENT specialist sooner than later is critical, not only to know whether there's conductive hearing loss, because then that needs an ENT reflex referral, And if it's sensory neural hearing, then do we need to address the tinnitus from a standpoint of getting tinnitus retraining therapy? And those things are very important because we know tinnitus is a brain process. And getting the right devices is key because tinnitus drives patients crazy when they're recovering from concussive injury. Even if they're not recovering from concussive injury, you all know more than I do, that it is a very significant hindrance to their day-to-day existence. And since Natalie's the expert on that, I'm just going to let her talk about that. But that's the reason we put this slide up, is to understand balance of function in the brain. The brain wants integration and balance. That integration is that processing dysfunction that's occurring. So surprisingly, and not so surprisingly, in descending order, 75 to 45% of people with vestibular dysfunction complain of headaches. So they think, oh, I've got a headache, and I had a headache before the concussion, and now I have a headache that's worse, and that's probably related to a brain bleed, which is not the case typically. And 90 to 98% of imaging studies are normal in mild traumatic brain injury. But the headache gets better when vestibular function gets better. They move faster when vestibular function gets better. The concentration improves. The dizziness improves. The fogginess improves. Cognitive and physical fatigue improves. Vision, blurring, and double vision. Of course, we get it evaluated to make sure there's nothing wrong with the retina. But if the retina is fine and you still have diplopia, then the diplopia is more likely than not coming from the vestibular system. And then the light sensitivity is coming from the vestibular system. And the memory difficulty highlighted in red, we've shown now in hundreds of patients, as you improve vestibular function, you improve neurocognitive function. And last but not least, of course, we all think that vestibular dysfunction is associated only with balance problems, which we know is not accurate because there is numerous other symptoms that patients feel. Speaking to that last statement, here is the integration. So if you look at the left-sided panel where it says sensory input, we know the integration of input in the brain is coming from three senses, right? Vestibular, visual, proprioceptive. The integration, what I want you to pay attention to is on that first big rectangle, the upright rectangle, and under integration of input, is that the VOR is basically not only controlling balance, but the VOR is also providing input into the brainstem through the pathways, which is integrating sensory information and then communicating with the higher centers that contribute to thinking and memory. And that is the key reason we have to evaluate the vestibular ocular system to make sure that patients understand it's not just balance and it's just not motor impulses, because we know that the VOR is basically the reflex that originates in the vestibular system through the middle ear. It goes to the brain, the eye, and the postural muscles, to all three, right? It provides input into all three. And therefore, understanding that cognition is linked to that is key for success. And just to elaborate a little bit more on what I talked about previously about postural and gaze instability contributing cognitive impairment in the setting of vestibular dysfunction, this little graph from Bigelow and Agrawal basically talks about the importance of visuospatial ability, attention, executive function, and memory when there is vestibular involvement. Our experience, since we had put this presentation together, we've seen another 50 new concussions, and currently we're getting 5 and 6 phone calls a day for new concussions. And we have learned that when you leave vestibular dysfunction untreated, you can induce prolonged changes in cognitive function. And we're excited to share this data in about 12 months from today. And conversely, if you do good rehab, early good rehab, there is improvement in cognitive function, specifically memory processing speed, reaction time. And as we know from the building blocks of brain, when the basement of cognition is affected, then executive functioning of initiation, planning, memory functions are affected. And we'll talk a little bit more about this later in the talk. Again, I will let you read the Gurvich article and not bore you with the fine print here, but this speaks to the fact that we talked about cognitive dysfunction being affected by vestibular dysfunction. Similarly, The 3 studies by Guidetti, Smith, and Haynes speak to this, but they also speak to the fact that individuals who have vestibular dysfunction as untreated, especially if they have a pre-existing anxiety and depression, it can worsen if the vestibular function is not corrected. I will let Natalie jump in here to talk a little bit about what she does.
All right. So great job here. So I have to kind of say that as an audiologist, for many, many years, it wasn't until I met Dr. Mystery that more of this integrative approach to managing concussions and brain injuries came to light. And it got fun for both Dr. Galloway and I because we were able to look at audiology a little bit different, right? And look at some of the things that, besides balance, what else do we look for when somebody sends just a VNG or just dizziness or, some of the other symptoms our way. And so it's been kind of fun because we get to integrate some of the other things, even though we're an integrative approach with other specialties and other providers within audiology. I feel like we are actually using that integrative management and that care even within audiology. And it's allowed us to continue to do some fun things with audiology that not a lot of other audiologists get to do. So it's really kind of cool. This is definitely taking our practice to a new level to be able to see some of Dr. Mystery's patients with him and the team. All right. So with audiology, typically, we do the hearing where we assess, first of all, when they come to us, we get this great referral, but we ask questions on the phone. And we're basically asking, are you noticing a hearing loss? Are you noticing, difficulty hearing in noise? Not just a hearing loss, but difficulty hearing in noise. Because most of the times we might see that their hearing is normal, right? So when we ask about the difficulty hearing in noise or being exhausted after being in a noisy environment, we're looking for auditory processing deficits, right? Something that we need to test further. In addition to typically they have headaches, like Dr. Mystery said, as well as balance issues. Then we take them through the VNG and the VEMP. We also ask if they've got tinnitus and sound sensitivity, because again, that allows us to look at how severe is it and do we need to have them go through some type of treatment. And then as we're doing the testing, we determine if there's imaging that's needed from our testing or other tests or therapies as we're going through all of our testing for these different patients. So in my experience, we're going to kind of cover a few different areas of audiology. So like I said, auditory processing deficits. I should have figured out the percentage, but there's a lot that come through that still have normal hearing. So we probe a little bit further to find out if after the brain injury or after the concussion, are they noticing more difficulty when there's lots of different inputs coming in? And it could be, photosensitivity. It could be, when they're in a restaurant and there's multiple conversations or a meeting, or it could be just basic noise, right? Maybe they're in a gym or someplace where there's a lot of other noise and other stuff going on. And it's like they can't hear the person right next to them, or they feel exhausted. So we probe a little bit further to figure out if we need to do an auditory processing disorder evaluation. This is the code that we use. We kind of book it for about 60 minutes. And then through our evaluation, there's rehab options. And so, yes, we still go with mild gain amplification, whether they have hearing loss or not, because the circuitry of a hearing aid is going to be able to help the speech be pulled out from the noise, right? And help suppress that a little bit. So even with normal hearing, mild gain amplification can help. We give them the apdsupport.com website where they can do some auditory training on their own, sign up for it on their own. It is a paid type of rehab training. So we let them know. And then if they're school aged as well, because we do see some school aged kids, then we go a little bit further to make some recommendations for accommodations, right? So whether it's being able to get the teacher's notes or summaries, whether it is involving the teacher or the aide to help by reminding them to try to rephrase maybe preferential seating. Direct audio input always works because it increases the signal to noise ratio. If the teacher is wearing, a microphone and the student is wearing either a a set of hearing aids or a headset or even a speaker that sits on their desk to be able to get that direct audio input and minimize as much noise that could be mixing with that signal. Then that would help as well as just kind of giving some ideas to modify the acoustics in the classroom. So that recommendation would mean that we would go to a school and actually look at certain things, see the schedule of the student, and then sit down and talk to the teachers and the aides as well. Even the students, sometimes even educating the students when you do a school visit is great as well, so that they understand what's going on in the classroom. So that's with auditory processing disorders. Then again, as usual, we look at the dizziness, and typically, we schedule a 90 to 120 minute appointment so that we can get a VEMP done and a VNG. Sometimes we don't do the VEMP depending if we see those characteristics of that low frequency conductive hearing loss in a hearing test. Or like I always ask them, and I know it sounds weird, but I always ask them, I'm like, do you hear an echo of your own voice in your head? If I tap on your knee, are you hearing it, in your head, right? And so we're kind of ruling out some different things to see if we do need to do the VEMP, but typically we'll do the VEMP and the VNG. Obviously, we're ruling out peripheral or central, as well as trying to see if, typically I would say if vestibular rehab is needed. However, thanks to Dr. Mystery and the Asher Brain Clinic team, what's fun is that we had an in-service, and we're going to have continuing in-services. And so I'm learning a lot about that. It's not just recommendation for vestibular rehab. It's not just in our normal VNG looking at the unilateral weakness, right? But we want to start tracking what happens when they do vestibular and ocular rehab, occupational rehab, right? So all kinds of different things with a PT or an OT, trying to see if some of the things that we're doing is making that improvement. And so we had talked among ourselves on the team that we're going to try to reevaluate more patients after they follow the treatment so that we can kind of see, hey, technically, if this is what their diagnosis was and they're going to go do rehab, then they should be improving. And so we're going to start to have these patients come back following a treatment and track that. So the next time we're back, we'll be able to present, like Dr. Mystery said, we'll be able to present within about a year at least, some of the trends that we're seeing with therapies and exactly what's going on after they leave, and if they're coming back, what kind of improvement they're seeing. And so I love being part of the team because, again, we get to evaluate not just the inner ear, but we get to talk about what's going on in the system of the patient, right? Like what Danny was saying is just, that whole integrative approach. And so that's been kind of fun as well. All right. So then I wanted to present a case study. So we actually had a couple of different athletes come in, and they were young. They were in middle school, high school, and they were traveling in a van, and they were hit by a semi truck, and the van rolled over multiple times. So I think I probably saw 3 or 4 different athletes. This one was probably the one that had the worst amount of symptoms out of all of them, but we just wanted to see where they were. It was a pretty severe accident. This patient lost consciousness. She had symptoms of dizziness, headaches, and she also had some compression fractures in her back. Now, by the time that I saw her, her symptoms have improved, she said. There was no complaints of hearing loss or tinnitus, but for her as an athlete, it was hard to be in a loud gym. So again, these different types of history questions kind of points us to, okay, what else needs to be done, right? What can we do? So again, we checked the hearing test just to make sure, even though she said she didn't have any complaints of hearing loss, we still do the hearing test just to kind of see the peripheral system, right? And then with the VNG, what we found that there was some nystagmus in positioning and positional nystagmus, not rotary, so not BPPV, but that nystagmus fatigued and fixated. And then her calorics indicated that she had a 35% left unilateral weakness. So what I did was we recommended vestibular rehab with core stability. And then depending on her symptoms as she comes back in, or as she goes through, different rehab, or as time goes on, right? I said, if you're still struggling in the gym, if you're still struggling, we don't know yet if it's sound sensitivity or auditory processing, right? And so I said, if it's still bad, if you're starting to reach for earplugs, come back and let me talk to you about that, right? Or if you're struggling in the gym still, it could be the APD side, right? So we want to consider further evaluation if we need to as time goes on. And then again, because she had that left unilateral weakness. She will be one of those ones that after rehab, after time goes on, that will plan to reassess her. So that was just kind of a simple yet interesting case study in the dizziness realm. And then we go to tinnitus. And so we talked about APD, we talked about dizziness, and now tinnitus. And so, like last year, we presented more about tinnitus. So in my experience, what we normally do is we start off with a consult first, because we want to really weed out and make sure that it's not just amplification, or it's not just being, tinnitus has increased, but they're able to cope with it. But we want to make sure that if they are really bothered by tinnitus, and we do the testing and the evaluation, right, and we get a good history, that we can actually do something and they will see benefit. And so last year when we presented, codes have changed. And so in the audiology consult code, those are some of the different codes. We do use a 99 code. I know that a lot of audiologists are saying, well, we can't do 99 codes. You can. The 01 to 04, like physicians, are based on the amount of time you spend, right? Then we go into the evaluation, and those are some of the codes that we use, same 99 codes in the directive counseling part. But I was trained in tinnitus retraining therapy, so I take my time to make sure that the patient understands the neurophysiological model of tinnitus and why sound therapy will help. And if it is with sound sensitivity as well, we kind of start with the consult to weed out the different sound sensitivity issues, whether it's misophonia or hyperacusis. And then we go through the evaluation as well. All right. So with the tinnitus consult, this is just my sheet. I know it's really small and blurry, but that's just my worksheet that I use to when I take notes with patients. I scribble all over it, but we do have some questionnaires that we deliver. And, if they become my patient, they do those questionnaires every single time they come in, because we want to make sure that we can benchmark, and we can see on that day that they're in, when I'm testing them or when I'm having my visit with them, how are they ranking their tinnitus? So basically that's what the questionnaires are for. We take a good case history. We look at hearing loss, tinnitus, and sound sensitivity. So those three things, because we want to make sure that we rank it out. Obviously, if they have sound sensitivity, we need to treat that before we even get to the hearing loss or the tinnitus. These are some case histories based on that. So this is basically what's on that little sheet that was super blurry. The basic questions, obviously, for tinnitus is, where is it, right or left, intermittent, constant, does it fluctuate in volume, when did it start, how would you describe the sounds, do you have bad days versus good days, what's your percentage of awareness and disturbance, does it affect your sleep patterns, and then also asking if there's any underlying medical conditions. Then other questions are finding out where tinnitus is affected, where in their life does it affect. This one I love. When you leave a loud area, is it worse? Because we're looking for, the type of tinnitus that actually gets worse, the reactive tinnitus. I like to look for the support system. So who do you live with? What do you do for work? How many hours do you work? And then any increased stress levels, because this is where it comes out, where I can see that there are other factors that might affect their tinnitus therapy, right? And so we got to talk them through that. Or do I have to actually make recommendations or work with a clinical psychologist to help them reduce stress levels or sleep patterns? Recent colds, viruses, changes in medications, exposure to loud sounds. This is all just noise exposure type of things, or anything that can make their tinnitus fluctuate. If they use ear protection, what treatments have they tried? And I always like to ask, why is tinnitus a problem? And it's an open-ended question. I just like to hear what they say and write that down as well and try to see what's going on. Then we've got the case histories for sound sensitivity. Just if they have oversensitivity to moderate everyday sounds, not sudden or loud sounds, but just everyday sounds that we are okay with, but because they may have a brain injury or concussion, they could have oversensitivity to moderate sounds, like closing of the garage door, a blow dryer, putting dishes away, things like that. So those are just normal everyday sounds. And then if they've got physical discomfort for other sounds, just kind of tracking every single sound that they're having a problem for. And so you want to make sure that with this and sound sensitivity, you definitely specify that it is moderate everyday sounds. Again, similar to the tinnitus questions of when did it start, as well as does the sound sensitivity affect and prevent you from activities, and then have you tried anything specific? I always like to see what they've tried to see if I need to break that mindset of, oh, I've already tried something, so this is not going to work, right? So I'm trying to see, well, what exactly have you tried? So those are some of the case histories. Questions for sound sensitivity. Then we go into the directive counseling. This is where I go into that neurophysiological model of sound. We go through statistics and definitions. We tie in the Heller and Bergman case. I love this report that they took normal hearing people, put them in a booth. Whenever they and then they said, whenever you hear something, push the button. Then they walked outside, closed the door, and didn't present anything. And 94% of normal hearing people pushed the button. So they proved two things in that research. Number one, normal hearing people can have tinnitus. And number two, that when you're in a quiet environment, you're probably going to notice your tinnitus more. So it helps me to show them how sound and living in a sound enriched environment is going to help them with their tinnitus and their sound sensitivity. And then we kind of go over pricing for devices and therapy. And if they need to check into insurance, then we will give them codes for them to check in to them as well. Then for the tinnitus evaluation, again, those questionnaires. And then with the tinnitus evaluation, we've already done the hearing test. So these are just some of the other tests that we do to check for hearing loss up to 12,000, otoacoustic emissions, loudness discomfort levels if we have not done that, to look for the type of sound sensitivity, and then these and then these tinnitus parameters, I should say, tinnitus loudness match, which is the TLM, broadband noise and narrowband noise minimum masking level. So that's telling me their perception. Sometimes what's interesting is the tinnitus loudness match could be anywhere from 1 to 2 decibels. With my audiometer, I change it to not a 5 decibel difference, but 1 to 2 decibels, up to sometimes it's like 30, but the minimum masking level, which is really interesting, is even if the tinnitus loudness match is, let's say, 4 decibels, their minimum masking level, which means the amount of sound that I have to put in their ears for them to perceptually feel that they do not hear their tinnitus anymore, can be like 40. So on a 2 decibel noise, they're telling me I have to give them 40 decibels of noise in order for them to not hear their tinnitus. And so again, going back to the perception, that's why it's so important to understand that neurophysiological model of tinnitus, because their perception is inflated, right? They're saying that a 40 decibel sound is covering a 2 decibel sound. So, again, talking them through that, but that minimum masking level is huge. And that's how I know, and that's the progress that I see in my tinnitus patients, is does that minimum masking level decrease? And it should with sound therapy. And then we talk about, usually I invite them back with their spouse or their family members, and then we talk about some of the different options and strategy for their tinnitus treatment. So there are some important points to remember for tinnitus sound therapy. I think, we talked about this last time, but really, again, using sounds, you want to make sure that it's pretty much 24 hours of sound, okay, that they should never strain to hear. So if they have a hearing loss, that it is important to couple your tinnitus therapy with amplification. The sounds that you're giving them to treat their tinnitus should never evoke annoyance. And the reason why is because of that neurophysiological model. If they are annoyed by the sounds, then they're going to have that reaction, that brain reaction, and we don't want that to happen. The sound should not sound like their tinnitus. So I'm not matching their tinnitus in my evaluation to give them their own sounds, because they already have an aversion to their own tinnitus. So we want to make sure that the sounds that you're giving for treatment is neutral, where they hear it, but they're like, yeah, my brain doesn't recognize this. So what? I'm not going to pay attention to it. Versus if I gave them their own tinnitus, they're like, ooh, there's that sound again. I don't like it. And like, they're going to start having this brain reaction, which is an emotional reaction as well. And then setting it and forgetting it. So you want them to set it and not touch it throughout the day. Sound sensitivity, again, based on the neurophysiological model of sound, there is 2 types that we really want to look for: hyperacusis and misophonia. And again, I won't walk through all of this, but there are different therapies for each one. So it's super important to figure out, do they have hyperacusis or do they have misophonia, and treat them appropriately. I think one of the things with hyperacusis, the biggest thing is that you can move relative to tinnitus and how you set your devices. With hyperacusis, you can adjust it throughout the day. Okay. Um, 3 to 6 months of therapy. I mean, that's a real deal. And so I wanted to point that out as well, because unlike tinnitus, where it takes usually 12 to 18 months of therapy to retrain the brain, and then you've got brain injury patients on top of that. So it probably takes a little bit longer, right, than 12 to 18 months of therapy. If you're treating hyperacusis correctly, you can be as quick as 3 to 6 months of therapy and then be done. Most of them are, I'd say 1 to 3 months and then they're done. But I would say average, for people that are starting off with hyperacusis treatment, I would say 3 to 6 months is good, which is fast for them, right? So I think I posted in one of our audiology groups that I think it was maybe a month. Yeah, a month. And my last patient was done with his sound sensitivity and we were able to move on. So that's really, really short. And then misophonia is music therapy, totally separate. Misophonia is when you have a physiological response that comes out because of a certain sound. Okay. So that would be a lot of people that misophonia, most common one that we see are people sniffling and eating and smacking their lips. That is a misophonia, where it's not a very loud sound. And typically it's only at home with their loved ones. They can go out, they can go to school, be fine with their other students. If it's a kid, they can go out to a restaurant or go to a meeting or at work and they're fine. They're fine with themselves. It is at home when they are with their loved ones is where that comes out, which is really interesting. Versus hyperacusis, these people are reaching for earplugs to put it in if a level of sound comes over a certain level. And anytime any sound comes over that level, they're going to reach and put some earplugs in or put earmuffs on. Versus misophonia are particular sounds. It doesn't matter on the level of the loudness of the sound. They're having a physiological response. So there's two different types. All right. So this was the case study that Dr. Mystery had talked about with this service officer that came to see us. This is one of our first cases together, which, I was so excited at how we were able to help this patient. And so this fellow was married for 28 years, lived on a very quiet property, after the accident, basically, right? His wife does not talk around on the phone around him. There was a mill that was 2 acres away at a house, and he said he could hear the high-pitched sounds from inside the home, and it was bothersome to him. He was very sensitive, but there was no physical discomfort. And anytime that he stepped outside of his home, he put foam earplugs in his ears. And so 3 years after the accident, he was seen, and he had some hearing loss, and he had hyperacusis. And I remember him being in my office, and he literally had his backpack on, and I was taking history with the wife because he could not stand anybody's voices, and he literally stood by the door ready to leave. Like, he was ready to leave. And so I let him stay in the room, but I talked to the wife and I lowered my voice. And then as I started to direct some questions to him, I kind of tricked him and I said, how about we continue this history in my other room where I have my sound booth, and you can sit in there, and the walls will protect you from some of the sounds, and that will be super comfortable. You can get comfortable in there, and I'll still talk to your wife out here. And literally, when you walk into a sound booth, it does mute a little bit, so that was good. And then I walked in after he sat there, and I started to ask him some questions. And then I walked him through, okay, this is what we're going to do for the testing. Will you allow me to test you? And he got so comfortable. He was like, yes. And I go, okay. I said, I will be watching you the whole time, and we're going to test you because I need to see where your loudness discomfort levels are. And I explained to him the test so he wouldn't be scared, as well as I really needed to get where his uncomfortable levels were. That's the only thing I cared about was, I really need to get these done, because what we had were these students that Dr. Mystery talked about were engineers, and they were called ear engineers, and they were going to develop a filtered earplug, an electronic filtered earplug that, depending on where his loudness discomfort levels were, they were going to program it in so that in each frequency, they could figure out how much sound needed to be attenuated. So I loved that project. And so I ended up being able to get that for him. So in the audiogram that you see, that small little box there, okay, we'll talk about the box first. Those U's in blue are his left ear uncomfortable levels. The red is his right ear uncomfortable levels. Okay, so that's where we first started. I was able to get them all the way across from 125 hertz to 16,000 hertz for both ears, 17 points of data. Now, just to give you, for those of you, just kind of a reminder, so 90 decibels and higher would be normal sound tolerance. 70 decibels to 90 decibels would be decreased sound tolerance, and anywhere from 70 and lower would be hyperacusis. Okay, so he's pretty much at he starts off at 35, it looks like, in 45 for both ears. And I think the lowest peak, or the highest peak, I should say, that he was able to tolerate, I believe, is at 70 in that, it looks like 4,000 hertz on that left side. So it kind of peaks down there. Peaks down there is kind of funny. It drops notches. Okay. So then after, and then you can see the, did I write that out? Yeah. So then after that, we worked with them and they ended up making these, it's actually these filtered headphones that you see him wearing. And his wife sent us some pictures during Thanksgiving. That was the Thanksgiving picture where he has these headphones on that are filtered that allowed him to have Thanksgiving dinner with his family. And then the other picture with the yellow sweatshirt and the green hat is him walking into Black Friday. So he went Christmas shopping on that same day. So his wife was super happy. We were able to get that data so that the ear engineers were able to make these customized filtered headphones. And for someone who was not able to leave the house, his wife was very, very, very happy. So it was a pretty amazing case. I love presenting this case. It made me so happy. And I think that's it. So I'm going to pass it back over to Dr. Mystery.
Fantastic, Natalie. I mean, I'm very grateful for Dr. Phillips's work, and I don't even know the number of patients have been better because of this integrative, thorough approach that she has. You know, we talked a little bit about the present and the future at the in-service because one of our occupational therapists, Mandy Shaki, who works for Colorado in Motion in Fort Collins and sees most of our patients with concussive injury, she had talked about the fact that she'd been observing that people who have follicular, if they have vestibular weakness that's less than 20%, which is considered normal, she was still seeing clinical signs of vestibular dysfunction. And so we had a meeting and said, where were these norms developed, right? So our understanding now is that most of these norms are developed from people with vestibular neuritis. And the question becomes, do we develop norms for patients with MTBI? And the answer is we should, because of the correlation that we find with someone who has even 12% weakness, unilateral or bilateral, and what is the significance of that percentage, even if it's less than 20%? So one of the things we talked about doing was repeating the test, because akin to anemia or any other dysfunction or metabolic dysfunction, we do a retest, right? We give people Synthroid for thyroid dysfunction, and then we retest the TSH and free T4. Likewise for anemia, with checking the hematocrit and hemoglobin, and checking iron studies for iron deficiency anemia. So we've started doing that, and we've seen, I think, 2 or 3, we've done a retest, and actually we've found interesting data which will be ready to present to you next year when we have a bigger N than just 3, because presenting any research with an N of 3 is borderline not right, to say the least. All right, I'm very excited about this aspect of things. Coming back to that integrative approach, as you can see, now we've sent our patient to Natalie and Hannah and any other audiologist or ENT doc. They've done their job. And then we move to the next slide. And we send them to neurooptometry to assess anatomical integrity, especially of the retina, if there is a problem with curtain vision, double vision, etc. Look at the need for prism correction, because we know from experience, concussive injury shrinks peripheral vision, and prisms allows enhancement of peripheral vision by shrinking the central vision. And in combination with prismatic correction is needed in combination with vision therapy, which is changing pathways in the brain for the better of the patient, not just correcting a Snellen's chart abnormality. I think it's important to understand the profound role of optometrists, ophthalmologists, and ocular vision therapists in good healing, but also to see if we need to image the orbits, and then if we need any further specialist referrals, like to a retina specialist. Next slide. We also know that post-traumatic vision syndrome is a very common problem, and I won't bore you with the details of the slide, but we do know that individuals with post-traumatic vision syndrome are unable to perceive spatial relationships between and amongst objects. They do not have the ability to perceive the entire picture or integrate that various parts of that given concept from the picture. They have poor visual memory and fail to attend to objects in their usual format or place. And this is typically caused by visual tracking issues, and they have disordered binocular movement, akin to you taking a binocular out of a case and not adjusting the binocular and looking through it. It's going to be blurred. The adjustment is ocular therapy, prismatic correction, etc., vestibular rehab, through correcting deficits of the vestibulo-ocular reflex. Next slide. We also know that individuals with post-traumatic vision syndrome can manifest any number of problems, including oculomotor dysfunction, binocular dysfunction. A lot of them have convergence insufficiency, excess, visual midline shift, especially in the more severe cases, visual vestibular mismatch, which we are trying to correct here, making sure those distortions which are rooted in neuromotor deficits are corrected, and then eventually correcting their delayed visual memory processing that allows them to function better cognitively. Next slide. And I'd encourage you to look at these two videos. They're relatively long. One is 2 hours long and one is 3 hours long, but it talks about the integration of vision and vestibular function, and terrific presentations which you can see on YouTube for free, and very well presented and makes a lot of sense. After optometry or in, so let me go back there. So we see the patient, we write the referral for audiology, ENT, optometry, ophthalmology is needed. It's important to also know that getting that cognitive function at baseline is very important. So we'll just talk a little bit about that cognitive function. If you can go to the next slide, Natalie. The key piece of getting our clinical and school psychologists involved and doing neurocognitive testing is to understand that the neurocognitive testing we do could be rooted in vestibulo-ocular dysfunction, but also is skewed in people with fatigue, migraine, and a history of anxiety, depression, and mood disorders. The assessment can be done through any number of tests, including impact. There are a slew of other tests our clinical and school psychologists can use. We assess the need for cognitive rehab, assess the need for psychological counseling, forgive that typo, and then our school psychologist communicates with the schools and other healthcare providers to check in on the patient on a regular basis, which then makes for good healing as we move forward. The reason to get that good cognitive testing is simply explained in this slide. The basement is memory, processing speed, attention, inhibition, sensory motor function. The first floor of a home is language processes, learning, etc. The second floor is higher order processes, and not just necessarily a home, but think about it as a commercial building. And then the overall functioning is affected, especially executive functioning is affected, including initiation, planning, organization, flexibility, and reasoning judgment if the basement is affected. So what we're trying to do is get that baseline cognitive testing done. And then if you look at the next slide, we want to fix this disordered basement because the executive functioning is affected. And when we fix vestibulo-ocular dysfunction, we fix executive functioning, shown in hundreds of patients, which is a very exciting process as we move forward in healing folks. This is just an example of an impact test where if you look at the red text, it talks about the post-injury testing, and then we retest them few weeks later, and as you can see, as they get the vestibular rehab, those numbers get better. It's also key to know that some folks may not have every score in the average, right? Different brains are different. The the average range is from 16th percentile to the 84th percentile. So many times people live in that average range, but doing that test retest is key to look at the effects of vestibular rehab, vestibular eval and rehab on how their cognitive scores are changing with time. Functional neurocognitive testing it allows us to basically help prioritize and direct changes to treatment. And many folks ask, why don't I just go get neuropsychological testing right away? Because a neuropsychological testing, just like any other testing in medicine, has a place and time. It's very expensive. It takes about 8 to 12 hours to do. And to have a person who has an acute concussion test for 8 to 12 hours is devastating to their brain. And so we have great neuropsychologists who work with us. And when the time is right to get that testing done, we can do it. But this functional neurocognitive testing in clinic is an important part of our model for success. Talked a little bit about the fact that functional neurocognitive testing can be done immediately post-injury and can document objective recovery over days or weeks or months until they're back to baseline. And the ones who don't get back to that baseline, or if their scores stall, then we get them to do the neuropsychological testing. Next slide. We talked about the clinical psych, school psych, neuropsych. We talked about the thorough vestibular ocular eval. Talk a little bit about integrative therapy. The integrative approach, we come back to the slide which we had presented earlier, now kind of makes sense, right? Because we have done the eval, we've done the therapies, and now we are going to retest the person and then refer them to neurology for medication management as needed. It doesn't have to be a same process for everybody. The only similarity in process is early intervention as far as vestibular ocular eval and treatment goes. And in some folks, that includes neurology as well. So I'm not saying that everyone has to wait for all of this before they see neurology. It's on a case-by-case approach. But our neurologists we work with will readily tell you that take care of the folks and then send them to us as needed. Next slide. You know, over the years, we've learned that in this field especially, you know, the brain and heart are one organ, right? And the brain thinks it controls the heart, and the heart thinks it controls the brain. We think we know it all. We don't. I kind of feel that despite the fact that I've seen maybe 2,100 to 2,500 concussions in my lifetime as a doctor, I always feel that with each patient that better is possible. You know, I love this quote by Atul Gawande from his book Better, where surgeons notes on performance. And it really does not take genius. It just takes diligence with every patient. It takes moral clarity to tell the patient, look, I don't know when you're going to be better. I know that if we do good vestibular ocular evaluation and treatment, you will get better, more likely than not. It takes ingenuity, and above all, it takes a willingness to try, not for us so much, but for the patient. And encouraging them to stay the course has made a tremendous difference in the lives of hundreds of patients. And so I'll pause here and let Natalie take it from here. We can't hear you, Natalie.
Sorry. I love that. I love that quote. Best practices takes diligence and a willingness to try. And so, you know, as we close off, thank you guys for tuning in and for the Florida Combined Otolaryngology meeting to include us again in a presentation this year. Hopefully next year we'll have a lot of great data to present, because I'm super excited about that. I am honored and blessed to be able to be part of such an integrative team, because again, it's best practices, it's diligence. You know, Dr. Mystery is probably one of the most thorough and caring physicians. And so if you have any questions about, if you're an audiologist watching this, if you are in ear, nose, and throat, if you are a brain concussion specialist, right? Brain injury specialist, reach out to us, because I think that we're on the cusp of something that really can take our care to the next level. And so with that, I'm going to see if you have any other closing thoughts, Dr. Mystery, and then we will be done.
Now, I just want to echo Natalie's thoughts about um, her being so thorough with every patient of mine, always being available, affable, and able. And I'm very grateful. I feel like I'm the luckiest doctor alive in Fort Collins and beyond. So thank you, Natalie, so much.
Oh, thank you. So it's happening up here in Fort Collins. It can happen anywhere. So you guys go out there and get connected to other professionals and get going on best practices. But thank you for having us.
Thank you.